My name is Stephanie Joya, and I'm a student nurse at Cedar Crest College. My article was Spirituality and Spiritual Caring, Nurses' Perspectives and Practice in Palliative and Acute Care Environments. The article was written by Susan Ronaldson, Lillian Hayes, Christina Agar, Jennifer Green, and Michelle Carey. The research problem and objectives. The problem was that spiritual caring has been a difficult area for nurses to articulate. This difficulty may be the result from the unclear nature of spirituality and from a general lack of language to define spirituality in nursing and to describe spiritual caring. The objectives were to identify and compare spiritual caring practice among palliative and acute care RNs, to determine any correlation between palliative care and acute care RNs' spiritual perspective and their spiritual caring, and to investigate perceived barriers to spiritual caring by the two RN groups. The purpose of the study was to explore nurses' perspectives of spirituality and their practice of spiritual caring in two specialist clinical environments, which was the palliative and acute care. This will add to the conceptual understanding of spirituality and spiritual caring in nursing by analyzing these concepts through nurses' knowing, which was through experience and knowledge. The research questions. Do perspectives of spirituality differ between palliative and acute care environments? Do RNs practice spiritual caring in palliative and acute care environments? Does spiritual caring practice differ between these two groups of RNs? Do RNs' perspectives of spirituality influence their practice of spiritual caring? What barriers to spiritual caring are experienced by RNs in palliative and acute care? And do RNs' spiritual perspectives and spiritual caring practices influence barriers to such caring? The significance to nursing. Oftentimes, nurses encounter patients that are at the end stage of their life, and the nurses may be unsure how to interact with these patients if they do not understand spirituality. So an example was the hospice care that was mentioned in the article, and that these nurses are often faced with spiritual caring, and it's important that these nurses know how to interact with patients and to understand the concept and meaning of spiritual caring. The theoretical framework. The framework in this study was the tools Spiritual Perspective Scale and the Spiritual Care Practice Questionnaire that were previously used by Reed and Vance, respectively, and the results from this study were then compared to the results from Reed and Vance. For the conceptual model, there was no specific map or model, but the researchers state that the clinical environments where the nurses work vary widely, and the practice of spiritual caring may also differ between environments. So psychiatric nurses report that the spiritual dimension is difficult to capture in patient-nurse relationships, and that these nurses identified the need for more knowledge on the spiritual dimension and its importance for patient well-being. This in turn led to the leap to introduce the model of spiritual caring and perspectives in different nursing environments. The variables. The independent variable was the specialist clinical environment, so palliative or acute care, and the dependent variable was the perspectives of spirituality and practice of spiritual caring. For the interventions, there were no interventions mentioned in this article. For this sample, there were 92 RNs total. 42 of them came from palliative care, and that was split into community and hospice. And then 50 RNs came from acute care, and there were 3 major acute care hospitals, and the areas that the nurses were pulled from were general, surgery, orthopedic, medical, and coronary care units. Those that were included in the study were consulted with the director of nursing services at each of the participating healthcare facilities, and those that were excluded from the study were those RNs working in high dependency units in the acute care facilities. The setting took place in metropolitan areas in Sydney, Australia. Ethical components. There was an ethics approval from the Institutional Ethics Committee prior to the onset of the study. There was also an informed consent from the directors of nursing services for their staff to participate. Data collection. The researchers contacted directors of nursing services initially to discuss the research and to obtain consent for their nursing staff to participate. The researchers also asked for guidance on how to proceed with the research in their facility, and is particularly how to advertise the study and get the staff to participate. The nurse unit manager was the staff member central to the researchers' success because it dealt with RN recruitment and participation. The data was collected using self-completed questionnaires that was comprised of socio-demographic data, and then 2 validated research tools on spirituality and spiritual caring. The tools were the Spiritual Perspective Scale, which was a 10-item tool using a scale rated from 1 to 6 for each item and the respondent's level of agreement with an item. So they strongly agreed or strongly disagreed. The second tool was the Spiritual Care Practice Questionnaire, and that had an assessment and intervention section where there were 9 positive statements rated from 1 to 5 on statements with responses such as very seldom or very often. And then there was a barrier section, and there were 9 barrier-related statements, and the participants answered with I agree or disagree. Results. The results were considered significant if the p-value was less than or equal to 0.05. The palliative care nurses scored higher in spirituality than the acute care nurses. This could be due to the palliative care RNs were older in age and had advanced experiences, causing an increase in their scores, and the palliative care RNs had more experience in their specialty. The results that were significant to the researchers were the demographic differences, and that was age, employment history, which included RN, specialty, and facility, and then the basic qualifications, which included degree and certificates. The study did not find statistically significant correlations between palliative and acute care RNs, spiritual perspectives, or spiritual caring practice, or their perceived barriers to such practices, which was opposed to Vance's study in 2001. Both groups of RNs identified insufficient time as their most common barrier to spiritual caring. Palliative care RNs' barriers were similar to Vance's study in 2001, but acute care RNs also found patient privacy equal to insufficient time as their most common barriers. Limitations. Acute care RNs were recruited from a targeted number of acute care environments in order to limit diversity. This may have impacted the results obtained. However, the researchers stated that the RNs were from large tertiary hospitals and their depth of clinical experience would have been sustained. The implications for nursing practice. So this study raised the profile of spiritual caring by adding clarity in palliative and acute care settings. The researcher recommends that there should be an increase in RN spiritual awareness and spiritual caring, and to overcome the spiritual barriers identified in this study. This can be done by spiritual self-awareness and growth. The researcher also recommended that in acute care environments, nurses are provided or should be provided with spiritual caring education specific to that environment, and also support which may be achieved through experienced nurse spiritual caring mentors. In addition, there is a need to determine if nurses' spirituality is a prerequisite for the provision of effective spiritual caring. There is also a need for nurses to document their spiritual caring and to articulate it with nursing colleagues and other health professionals. Conclusion. Palliative care nurses had more advanced spiritual caring, which could be related to the items previously stated. The researchers state that further research involving the acute care environment, in particular investigating barriers that may be preventing acute care RNs' engagement in spiritual caring, is required. And my references are included on this page, and I look forward to reading your feedback and answering any questions that you may have. Thank you.